a world-class surgeon can, execute this completely flawless, highly complex pelvic reconstruction. Like the sutures can be perfect, the tissue alignment precise, and then you can just completely tear it to shreds 3 days later by, well, going to the bathroom.
Right, yeah. It is honestly the ultimate medical paradox. I mean, we usually think of surgical recovery as this purely passive phase, like you lie in bed, you avoid heavy lifting, and you just let your body stitch itself back together.
I just rest and recover.
Exactly. But the literature reveals this hidden, everyday mechanical threat, one that can silently sabotage all that intricate surgical work.
And that is the core mission for today's deep dive. We are sorting through medical guidelines, physical therapy protocols, surgical recovery manuals, places like NHS Highland and Brigham and Women's Hospital.
Right, alongside some incredibly dense biomechanical studies.
Very dense. But we are laser focused on answering this one unexpectedly critical question, which is, can constipation after treatment affect healing?
And spoiler alert, the short answer is absolutely yes.
Definitely yes. But I mean, the mechanics of how it happens and the extreme lengths hospitals actually go to in order to stop it, it's just fascinating. Because, it's strange to think that something as mundane as bathroom habits could just undo a sophisticated operation.
Well, to understand the mechanics of that threat, we first have to look at the physics of downward pressure in the human body. Because the baseline assumption most people make is that, well, all pushing is basically the same.
Right, a push is a push.
Exactly. But a key biomechanical study in our stack totally dismantled that idea. They did this by measuring the difference between two very specific actions, the Valsalva maneuver and straining.
Okay, so I hear Valsalva thrown around a lot, usually like, when people are talking about weightlifting or scuba diving. What is it in a clinical context?
So the Valsalva maneuver is basically when you force an exhalation against a closed mouth and nose, like you're trying to pop your ears on an airplane.
Oh, right, okay. I know that feeling.
Yeah. The researchers wanted to see what that specific internal pressure does to the pelvic organs. So they took 17 healthy, continent women and 67 women with urinary incontinence. And they used a combination of tools to measure them.
What kind of tools?
They used a microtip transducer to measure the exact pressure gradients in the urethra and the abdomen. And they paired that with perineal ultrasound to, visually track the muscle movement in real time.
So they can literally see exactly where the physical force is going.
Precisely. And what the ultrasound showed during the Valsalva maneuver was actually a protective reflex.
A reflex, like an automatic response.
Yeah. When the women performed the Valsalva, the puborectalis muscle, which is this crucial sling of muscle in the pelvic floor, it actually became stiffer. It contracted.
Wait, really? It got tighter?
Yes. The distance to the pubic symphysis, that joint at the very front of your pelvis, actually got shorter. The muscle essentially pulled forward and lifted. It created this really tight support system for the bladder neck.
Okay, wait, let me get this straight. Closing your mouth and bearing down, like to pop your ears, that actually pulls your pelvic floor up. It makes it tighter.
The transducer data absolutely proved it. The body essentially anticipates the abdominal pressure from the Valsalva, and it instinctively engages the pelvic floor to brace against it.
Wow.
But then the researchers instructed the exact same women to do a straining maneuver. They were told to push downwards specifically as if they were trying to, defecate.
And I'm guessing the muscle reaction changes then.
Oh, the physiological response completely flips. Instead of bracing, straining leads to a really significant descent of both the pelvic floor and the bladder neck.
So it just drogs.
Right. I mean, during the Valsalva maneuver, about half of the continent women showed active pelvic floor engagement. But during straining, only 30% did.
And what about the incontinent women in the study? How did they react?
Their bladder necks descended much, much further when they strained compared to the continent group. Their pelvic floor basically just yielded to the pressure. It got out of the way to let something pass.
Okay, so let me visualize this. If the muscle gets stiffer during Valsalva and pulls everything taut, it's acting almost like stretching a drumhead.
Oh, yeah. That is a highly accurate way to picture the biomechanics.
Right, it creates a firm surface that supports whatever's resting on it. But straining does the exact opposite. The muscle just relaxes and drops down. So that's just dead weight, like dropping a bowling ball into a hammock.
Exactly like that. And when you picture that heavy bowling ball dropping into a sagging hammock, well, you immediately see the threat to a patient who just left the operating room.
Because the hammock was just surgically repaired.
Right. If straining pushes all those internal organs down with that much force, consider what happens when that hammock has literally just been surgically reconstructed.
Oh, gosh. Stitches are going to take the full force of that bowling ball.
Which brings us directly into what we call the post-op trap. A lot of these procedures involve fixing structures that have collapsed.
Like pelvic organ prolapse repairs, right? Where the bladder or uterus or rectum has started bulging into the vaginal wall.
Yes, exactly. Or repairs for obstetric anal sphincter injuries.
Oasis, right. The severe tears from childbirth.
Right, oasis. We also see this with rectovaginal fistulas, which are these abnormal tunnels that form between the rectum and the vagina.
And the sources mention that fixing those fistulas is incredibly delicate work, especially depending on the patient's underlying health.
Very delicate. I mean, if a patient has a comorbidity, say Crohn's disease, their tissue is already dealing with chronic inflammation.
Which makes it weaker.
Exactly. Or if a patient has obesity, they just naturally have a higher baseline of intra-abdominal pressure from their body mass. Healing an inflamed rectovaginal fistula under those conditions is difficult enough. But even in a totally standard scenario, surgeons often perform what's called a native tissue repair.
Meaning they only use the patient's existing tissue to sew everything back together. No synthetic meshes or anything.
Right, and relying on native tissue has a surprisingly high failure rate just on its own.
Yeah, I saw that. The anatomical recurrence rate for native tissue prolapse repairs, meaning the prolapse just comes right back, is anywhere from 16 to 29%.
Which is high, so the tissue is inherently weak to begin with. That is why it prolapsed in the first place.
So you stitch that fragile, weakened tissue back together. And a few days later, the patient sits on the toilet and strains.
And that massive spike in intra-abdominal pressure from the strain hits those delicate sutures. The clinical term for the worst-case outcome here is fascial dehiscence.
Which means the wound literally pulls apart.
Yes. The fascia separates, or, the stitches might actually hold, but the sheer downward force just causes complete recurrence of the prolapse right then and there. The surgery is ruined.
Okay, but I have a major pushback here, though. If straining is the ultimate enemy of these tissue repairs, and constipation is the primary cause of straining, we have to talk about the medication.
Ah, the opioids.
Yes. Surgeons universally prescribe opioid painkillers right after these major procedures. But opioids are notorious for causing severe, rock-hard constipation. So aren't doctors kind of guaranteeing the exact biomechanical pressure that will destroy the surgery, setting the patient up to fail?
It's a completely valid point, and honestly, it is one of the most difficult tightropes in postoperative care because, yes, opioids significantly slow down gut motility. They lead to that dense constipation.
But why use them at all?
Well, skipping pain management after a major pelvic reconstruction introduces a totally different but equally destructive physiological problem.
Oh, right, because if you're in agonizing pain, your body isn't just going to lie there relaxed.
Exactly. Your sympathetic nervous system kicks into absolute overdrive, your heart rate spikes, your blood pressure spikes, and crucially, you instinctively tense up.
You start guarding, right?
Yes, you start guarding your abdominal and pelvic muscles. And that constant rigid tension severely impairs blood flow to the healing tissues. Plus, it constantly pulls on the fresh sutures.
Wow. Okay, so you have to suppress the pain to stop the muscle guarding, but suppressing the pain basically paralyzes the digestive tract. That is a brutal catch-22.
It really is, which is why the medical team has to be proactively managing the patient's bowel function from the moment they wake up from anesthesia. Because the threat goes way beyond just popping a surgical stitch.
Right.
A paralyzed gut can escalate into a severe life-threatening emergency entirely on its own.
Yeah, let's look at the NHS Highland Adult Therapeutic Guidelines in our stack, because they paint a very different picture of constipation than, well, what most of us imagine.
Right, like if you're sitting at home right now feeling a bit bloated, you might just drink some coffee or eat a salad.
Exactly. But in a surgical unit, an inability to pass stool is treated like a ticking clock.
It is. When a patient complains of obstipation, which is the severe inability to pass stool or gas, the medical team has to differentiate immediately between a functional problem and a mechanical obstruction.
And a functional problem just means the bowels are sluggish from the opioids. Right?
Oh, yeah. Yes. But a mechanical obstruction means something is physically blocking or even twisting the intestines.
Which sounds terrifying. How do they figure out which one it is without opening the patient back up?
They rely heavily on abdominal x-rays or CT scans. And they're scanning for very specific red flags. Like, one of the most urgent visual markers they look for on an x-ray is the coffee bean sign.
A coffee bean?
Yeah, it literally looks exactly like a giant inflated coffee bean on the image.
Oh, wow.
And it's the hallmark shape of a volvulus. That's a condition where a loop of the bowel physically twists around itself and its own mesentery.
Like wringing out a towel.
basically. And when it twists, it pinches off its own blood supply. The tissue starts to die, leading to ischemia. It requires immediate emergency surgery to untwist the bowel before it just ruptures.
That is incredibly serious. The guidelines also highlight toxic megacolon, which is this other condition that can initially just mimic severe constipation.
Yeah, the symptoms feel similar to the patient, massive bloating, total inability to go, but the mechanism is entirely different.
Right. Toxic megacolon is this rapid, life-threatening widening of the large intestine.
Exactly. The colon basically loses its muscle tone and begins expanding dangerously. It's often triggered by severe infections like C. difficile or inflammatory bowel disease. And if it isn't treated fast, the colon can actually perforate, leaking lethal bacteria right into the abdominal cavity.
Okay, but even if the scans rule out a twist or an infection, and it really is just a massive backup of stool from the pain medication, the treatment for extreme impaction sounds incredibly invasive on its own.
Oh, it is. If the functional constipation escalates into severe fecal impaction and chemical laxatives fail, a manual excavation is required.
Which means exactly what it sounds like.
Yes. If the patient is fit enough, they are taken back to the operating theater, placed under general anesthesia, and a surgeon literally has to manually clear the impaction.
Gosh. So if you've just been discharged after an abdominal procedure and you're just kind of brushing off the fact that you haven't passed gas in 3 days, the guidelines make it crystal clear. You could be brewing a surgical emergency.
Exactly. The hospital staff aren't asking about your bowel movements to be polite. They are intensively monitoring you for a life-threatening complication.
So the patient is caught between two massive risks. Push too hard, and you tear your pelvic reconstruction to shreds, don't go at all, and you risk a bowel obstruction.
Right. Navigating safely between those two extremes requires some really strict mechanical solutions. And this is where the physical protocols from institutions like Brigham and Women's Hospital come into play.
Their post-op instructions are incredibly rigid about physical mechanics. I mean, starting with the lifting restrictions. They cap lifting at absolutely no more than 20 pounds.
And when you think about daily life, a 20-pound limit is super restrictive.
A gallon of milk is, what, 8 pounds?
Exactly. So that rules out picking up toddlers, carrying standard laundry baskets, moving bags of pet food, or even aggressively pushing a heavy vacuum cleaner.
Because any of those actions force you to bear down,
Right.
recreating that dangerous straining pressure.
Precisely. They also completely ban bending over at the waist.
You have to use your knees to lower your entire body, keeping your torso totally upright so you don't compress the abdomen.
Yeah, but the most granular physical rules apply to actually sitting on the toilet. They explicitly warn against hovering.
Oh, like hovering over the seat.
Right, because hovering forces your glutes, your thighs, and crucially your pelvic floor to remain highly engaged just to keep you stabilized.
Well, yeah, you can't fully relax a muscle if it is simultaneously being used to hold you up in the air.
Exactly, you have to sit down completely. And once seated, patients are taught this highly specific technique called the brace and bulge.
The physiology behind the brace and bulge is so fascinating to me. It's essentially a way to trick the body into passing stool without applying any downward force. Walk us through how the muscles actually respond to this.
Sure. So step 1 is taking 5 to 6 relaxed belly breaths. And this isn't just for calming the nerves. It actively deactivates that sympathetic nervous system we talked about, basically signaling the pelvic muscles to let go.
Okay, so relaxing first.
Right. Then step 2 is the brace. The patient braces their abdominal muscles by making an M or an S sound out loud.
Like actually vocalizing a humming or hissing sound.
Yes. Try making an S sound forcefully right now. You will feel your transverse abdominis, those deep core muscles wrapped around your sides. They engage and they actually widen your waist.
Oh, wow, yeah. It creates a stable outward pressure cylinder rather than a crushing downward pressure.
Exactly. It stabilizes the core without pushing the organs down. Then comes step 3, the bulge. The patient bulges the lower abdomen forward while making an ooh sound.
Just
Yeah. The vocalization of ooh is neurologically linked to the relaxation of the anal sphincter.
It's just remarkable how connected the diaphragm, the vocal cords, and the pelvic floor all are.
It really is.
It mirrors the way a singer does vocal warm-ups to control their diaphragm, or how LeMay's breathing is used in childbirth.
Exactly the same principle.
Because if your mouth is tense and closed, like when you're popping your ears in the Valsalva maneuver, your pelvic floor tightens. But if your mouth is making this very specific ooh shape, the pelvic floor drops and opens.
The two ends of the internal pressure system totally mirror each other. However, early in recovery, the tissues are severely swollen, and patients are often, understandably, terrified of tearing a stitch despite their breathing techniques.
Right, breathing only does so much for the fear.
Exactly. So when the vocalizations aren't enough to safely move things along, physical therapists introduce something called perineal splinting.
Which is a much more literal, hands-on mechanical solution.
It is. Perineal splinting involves the patient physically pressing two fingers against the perineum, which is the space between the vagina and the back passage, during a bowel movement.
So by applying firm manual pressure there, they physically reinforce the vaginal wall from the outside.
Right. It stops the weakened surgical repair from bulging outward under the pressure of the stool. And it physically redirects that vector of force downward to actually empty the bowel.
So you are literally acting as a structural brace for your own organs while they heal.
Yes, exactly.
But mechanical posture and breathing only work if the stool itself is, movable. If the opioids have turned everything into concrete, no amount of humming or splinting is going to help.
Very true. And that is when the medical team really has to manipulate the patient's internal chemistry.
Chemistry becomes the final safeguard.
Exactly. Which starts with the diet. The dietary baselines are totally non-negotiable. 1.5 to 2 liters of fluid daily. The goal is to strictly avoid what the Bristol stool chart classifies as type 1 or type 2 stools.
Which are those hard, separate lumps, or the really dense, cracked, sausage-like shapes. Basically, any stool that requires actual muscular effort to pass.
Right. And to prevent that, hospitals heavily rely on osmotic laxatives, things like Laxido or Movicol.
And the mechanism of an osmotic laxatives is brilliant, because instead of stimulating the bowel muscles to squeeze, which, could cause cramping and pain,
Yeah.
it does something else entirely.
Exactly. Osmotic laxatives work by drawing water from the surrounding interstitial tissues directly into the bowel lumen. It basically floods the colon with water, keeping the stool soft and bulky enough to trigger a natural, totally effortless movement.
They also use docusate, I saw, which lowers the surface tension of the stool, so water and fats can just penetrate it easier.
Right, stool softeners are huge here.
But the sources contain this very specific, glaring warning about one class of laxatives, and it comes from the Royal College of Obstetricians and Gynecologists, specifically regarding patients recovering from oasis repairs, those severe anal sphincter tears.
Yes, this is a crucial distinction. The RCOG guideline explicitly states that bulking agents should not be given routinely with laxatives for these specific patients.
Which feels so counterintuitive because we are constantly told that fiber and bulking agents are the absolute gold standard for good digestion.
Well, in a healthy digestive tract, they absolutely are. A bulking agent like psyllium husk, it basically acts as a massive sponge. It absorbs water and creates a very large, bulky scaffold for the stool.
Right, but for an oasis patient.
Right. Consider the physical anatomy of an oasis repair. You have a freshly stitched, highly traumatized anal sphincter. If you force a massive, artificially expanded stool through that narrow, healing ring of muscle, it will literally stretch the repair beyond its breaking point.
The bulk just bursts the stitches from the inside out.
Exactly. It causes wound adhesions. So for oasis repairs, the stool has to remain soft but never excessively bulky.
Wow. Okay, so mechanical posture, osmotic gradients, careful avoidance of bulking agents. It is this incredibly fragile ecosystem.
It is.
And managing that fragility has to be exhausting for patients. Which I guess explains why surgical engineering has evolved the way it has. Because if native tissue repairs fail up to 29% of the time, and relying on perfect bathroom mechanics is this difficult, surgeons obviously had to find a way to make the physical anatomy inherently stronger.
Right. They realized they couldn't just manage the pressure externally. They had to actually reinforce the structures taking the hit. And that led to the widespread adoption of synthetic surgical meshes to support the pelvic floor.
But the literature highlights a pretty significant learning curve with that technology, doesn't it?
Oh, definitely. Early on, surgeons relied heavily on rigid synthetic meshes, like this widely used product called Restorel.
The idea being that rigid plastic would lock everything in place, so little straining just wouldn't matter.
Right, in theory. But the human body does not tolerate rigid materials well at all. The pelvic floor is a highly dynamic environment. I mean, you cough, you laugh, you move, you pass stool. The intra-abdominal pressure is constantly shifting.
And because the rigid mesh didn't yield to those pressure spikes, it just didn't flex with the tissue.
Exactly, it twisted. And over time, that twisting behavior basically turned the rigid mesh into something resembling a cheese wire.
Ouch.
Yeah. It led to severe complications, specifically erosion, where the mesh would literally wear its way through the vaginal wall or erode straight into the bladder or the bowel.
Okay, so if native tissue is too weak to withstand bathroom straining, and rigid plastic mesh is too stiff and literally cuts through the organs, how do surgeons reinforce the repair now?
The field is heavily shifting toward biodegradable implants. The engineering behind these meshes is designed to align with the body's natural healing timeline.
How so?
Well, they provide robust, rigid support during those critical first few months when the fascia is the weakest and most vulnerable to intra-abdominal pressure. But as the body forms its own mature cross-linked collagen around the repair site, the mesh gradually degrades and is absorbed by the body.
So it just acts as a temporary scaffold, completely vanishing before it can cause long-term erosion or chronic pain.
It's exactly.
Stepping back and looking at all these protocols, the osmotic laxatives, flooding the bowel with water, the specific vocalizations to trick the sphincter into opening, the biodegradable meshes that temporarily absorb the force. Every single intervention is designed around one core principle.
Which is?
The entire goal of postoperative healing is creating the path of least resistance.
That is a perfect way to summarize it. Removing mechanical resistance is genuinely the only way to protect the integrity of the repair, because pressure is the ultimate enemy of healing here.
It completely reframes our understanding of surgical recovery. It is a highly active process. Your body isn't just passively healing while you sit there and watch TV.
Not at all.
Protecting a delicate internal repair requires your active management of fluid osmosis, biomechanical posture, and precise vocal techniques just to safely use the bathroom.
And the data shows that when that path of least resistance is actually maintained, the body's capacity to heal is just remarkable. The RCH guidelines note that 60 to 80% of women are entirely asymptomatic 12 months after a severe oasis repair. The surgical techniques really do work beautifully when they aren't subjected to devastating internal pressure.
Which leaves us with a final thought to consider. We've just explored how a specific angle, a rigid breath, or even a slight strain can physically tear apart a reinforced surgical repair in a matter of days. If that kind of mechanical pressure is that destructive, what does that mean for our everyday habits?
That's a great question.
Because the vast majority of us sit on high, chair-like toilets. Forcing our pelvic floors to work at an angle human bodies just didn't evolve to use, rather than naturally squatting. If a bad angle and a bit of straining can ruin a surgery in a week, could our modern bathroom plumbing be silently, slowly degrading our pelvic floor health day by day, long before we ever need to see a surgeon? It's something to consider the next time you sit down.
A fascinating, if slightly unsettling, mechanical reality to think about.
Until next time, keep diving deep.